Today's interview for the archives of the American Association of Neurological Surgeons is that of Dr. Russell Meyers, being recorded in Pensacola, Florida, on April the 29th, 1989. Dr. Meyers, I wanted to ask you a bit about your early education. You were born and raised in Brooklyn.
Yes, sir.
And then you had taken your undergraduate work at Brown University. How did you happen to go to Brown rather than stay in the New York area?
It was largely a matter of an opportunity to get an athletic scholarship. I had been competing in the New England Interscholastic Championships in 1923, spring of 1923, and won the high and the low hurdle races there. And some of the Brown alumni and students got a hold of me, persuaded me to seek admission to Brown, and I accepted.
Well, you're still competing in athletic events in Pensacola, aren't you?
Well, yes. I've been in the master's program in the 75 to 80 age group, and have won a couple of world's records and a couple of world's championships in the hurdle races for my age group. And I have since then, since 1981, I've had to limit my activities to jogging rather than track events.
Now, you had mentioned earlier that your father was an architecture?
Yes, architectural designer.
Designer.
Yeah.
And he had hoped that you might enter the same field, do you think? Or?
No, he had no ambition for me except possibly to become a professional baseball player, whence he thought I could earn some money toward my education. But I didn't work out as a baseball player.
I see. And then you had learned, though, from him a lot of artistic techniques and skills.
Yes.
And then at Brown University, you had said that you became interested in physiology and psychology through serving as a student instructor.
The student assistant, laboratory assistant.
Laboratory.
In the biology courses, yes.
And then because of that, you in turn became more and more interested in psychology.
Yes.
And then you took your master's in psychology at Brown University.
Yes, sir.
Then you had talked about on leaving there, completing your thesis in New York, but having enrolled in Cornell Medical School.
Yes.
While living in Greenwich Village for $9 a month? Is that what you said? $8 a month.
$8 a month.
And
that was during the Depression days.
Yes, but it'd be hard to do today.
Very.
And
be lucky if you could get a pack of cigarettes for $8 today.
But you were working at Washington Square College. Was that part of the old City College of New York system at Greenwich Village?
Yes. Yes.
And
but was at that time I was teaching there part time while I was working my way through medical school. It was a accessory to New York University, the main college being way up in the Bronx.
Right.
Rather than at Greenwich Village.
Yes. Now, while you were teaching there, you'd mentioned it was in the evenings.
Yes.
In 2 courses. What were you teaching?
Well, they started me off teaching elementary psychology, introductory psychology, and then because of my then growing medical background, they asked me to teach physiological psychology, and then during the summer months to teach abnormal psychology during the day and experimental psychology during the evening, so that I had a rather broad spectrum of exposure to the teaching problems of those subjects, which served me well in medical school, running pari passu with the
Yes.
efforts as a psychology teacher.
You mentioned that in about your junior year, you took a course in neurology in medical school.
Yes.
Under Dr. Foster Kennedy, whom I suppose most every medical student, not just neurosurgeon, has heard of.
Yeah.
But what sort of a man was he? Was he a formal person or a bit informal?
He was an English gentleman, if that metaphor applies. He was, however, something of a dictatorial or autocratic chief of service. No one dared to contradict him on rounds or anywhere else. But on the whole, he was extremely kind to me, in part, I think, because I had won the Foster Kennedy Prize in neurology as a student at Cornell, where he was head of the department. And through that inside track, he offered me the residency on his service at Bellevue Hospital. Even before I graduated from medical school, I gladly accepted. And after I'd had my first neurosurgical residency with Dr. Browder, I went to Dr. Kennedy, who ran a neurology department which included the neurosurgical aspect of neurology at that time.
Did Foster Kennedy have any particular interests, special areas of interest in neurology?
Yes. He wrote in the first place, he had designed the Foster Kennedy syndrome before he left Britain. But he wrote a good deal about infectious diseases, both viral and bacterial, while he was at Cornell. And when he was associated, when he became associated with the psychiatric department at Bellevue, he began to bridge the gap between neurology and psychiatry, and had a good deal to do with the wedding that eventually resulted therefrom, called neuropsychiatry.
Yes. Now, when you had gone to work with Dr. Jefferson Browder at Kings County, you had mentioned that his background had been primarily in general surgery.
That is right.
And that he had spent some year, did you say, with Dr. Cushing at...
No, he went there as a fellow.
As a fellow.
And I believe he spent 2 years
2 years.
there. His background, as you indicated, was that of a general surgeon.
Yes. But he was the first neurosurgeon, I assume, then at Kings County.
Yes, yes. He was chief of service at Kings County Hospital and was looking for a resident when it happened that I was thrown out of my internship at the Brooklyn Hospital for amusing reasons, all of them professional.
Yes.
And when he had gotten to know me by my assisting him in as many operations at the Brooklyn Hospital, where he was chief, as I could, and sort of took me under his wing there. He picked up on my being fired from the Brooklyn Hospital and asked me to accept the first residency at Kings County Hospital, which I did. It was a saving grace for me to be able to move from one hospital to another without any break in looking for a job.
And it was following that you went over to Bellevue to serve in neurosurgery under Dr. Stuckey.
Under Dr. Byron Stuckey, yes.
You had mentioned that he was an orthopedic surgeon primarily, or initially.
Initially, he was an orthopedic surgeon.
How many years had he practiced orthopedics?
Oh, he did that in California.
Was he from the West Coast?
Yes, he was from the West Coast. I can't say how many years he practiced orthopedic surgery there.
But how many years were you at Bellevue then as a resident?
Just a year.
Just the year?
A year.
Uh-huh. And primarily was that management of trauma patients?
Trauma was a good part of the service, but no, by no means limited.
Did you work on neurology some too?
Yes.
Mm-hmm.
That was the appointment that Foster Kennedy had given me.
Was it somewhat of an unstructured program compared to our present-day residencies?
Decidedly, yes. In those days, it was common for a chief to be head of neurology and also to have on his staff neurosurgeons.
Yes.
Who did not have a division or department of their own.
Were the neurosurgical patients kept on general surgery then?
No, they were kept right on the neurological wards.
I see. That was a departure in a way, wasn't it, from
yes,
tradition?
most of them, for a long time after I got into the game, were carried on the surgical wards, general surgical wards.
You had conducted several experimental studies of increased intracranial pressure and the effects on so-called vegetative functions, pulse, blood pressure, respirations, in dogs and primates? Was it primarily dogs?
Just dogs and humans.
And humans.
Yeah.
And had found that the so-called Cushing reflex was not a predictable or reliable index of deterioration or manifestation of increased intracranial pressure.
Yes, that is so.
What do you think accounted for Dr. Cushing's earlier findings or conclusions, rather, and also the fact that it's become so ingrained in our neurosurgical and neurological teachings, even at the undergraduate level?
Yes. Cushing had done his experimental work on mammals under the aegis of the surgeon Kocher of Switzerland when Cushing was still on the staff at Johns Hopkins. His studies were very well done, but were limited only to the factor of increased intracranial pressure. But because his 4 stages of medullary compression were so neatly organized, they were picked up and carried over into the therapy of craniocerebrally traumatized individuals by practitioners. And so students of undergraduate students, as well as graduate and postgraduate students in training, were required to know the 4 stages of medullary compression as they would have been required to know the 10 Commandments. And this formulation was obviously failing them when I joined Dr. Browder at Kings County Hospital. And he and I were independent enough thinkers to say there's something wrong about this. There are many, many other factors involved in the manifestations of craniocerebral trauma than those of increased intracranial pressure. And we decided to attack the problem with experimentation both on our patients and on dogs, which we carried out at the Long Island College Medicine Department of Physiology. The upshot of those papers was to disabuse our colleagues of the virtues of adhering to the Cushing 4 stages of medullary compression. That met with a good deal of resistance, of course,
I would imagine.
because once people have inculcated themselves with a formulation, they don't thank you very much for you showing that they had been operating along the wrong principles for a long time.
As well as the eminence of Dr. Cushing.
Yes, as well the eminence of Dr. And Cushing himself never participated in urging that this be the one and the only criterion upon which to decide operation or no operation.
Yes.
He never advocated this. His studies were sound within the narrow framework of the studies themselves, but they certainly did not apply to the vast number of variables we had to deal with in craniocerebrally injured humans.
Did you come to conclude that there were any more reliable indices or index for increasing intracranial pressure, particularly from trauma, from rapid increases?
No, I can't say that our contribution was anything more than to show that Cushing's formulation could not be relied upon. It's hopeless to try to manage cases successfully, as determined by what we would find at autopsy. Every patient on Dr. Browder's service who died was one whose autopsy we witnessed or helped to perform, and on whom we made careful records attempting to correlate the clinical manifestations with the pathological manifestations. And these showed over and over again that you would be far better off not to have any formula, which would limit your lines of action, than to have a formula which was not serving you.
Yes. Why do you believe that this has persisted so long in our textbooks in undergraduate and graduate education, though? It's
well, that has to be explained
ingrained.
in terms of what sociologists call social lag or cultural lag. You might say, why was it that concepts that the Earth is flat were continued right up until the time that Columbus made his famous experiment? Because it was known by many individuals before the birth of Christ that the Earth is spherical. Many students of astronomer had published just that. In other words, we have to go back to the fact that there's an inertia. That once a formulation is internalized by an individual, he tends to continue to hold to that even when contrary evidence of a most flagrant sort is produced at the fringes of investigation.
Yes.
It was an easy formula to roll off and very easy to teach.
Yes.
And those were its main virtues.
In 1939, you had performed a rather early operation for Parkinson's disease.
Yeah.
And I wonder if you would relate a bit how that came about and your thinking about the site of making a lesion, how you chose to undertake the procedure that you did, and the results, and more or less what it led to next.
Yeah. Well, in that phase of history, the treatment of abnormal movement disorders, of which Parkinsonism is but one, was almost completely ineffective. The main drugs used at that time were atropine-like drugs like hyoscine and scopolamine and so on, but they made very little difference to either to the severity of the abnormal movements or to the persistence thereof. Operations had been done on the spinal, on the pyramidal tracts of the spinal cord by Tracy Putnam, and operations had been done in the neocortex by several surgeons, both in this country and in Europe, of which our Paul Busey was one, and Roland Clemmy of St. Louis was another. All such cortical operations depended for their improvement in respective tremors upon producing a paresis and a dyspraxia of the limbs on the opposite side of the brain subjected to operation. I sought to improve that, and as at that time the dichotomy between pyramidal and extrapyramidal diseases was already broadly accepted,
Who had originated that concept, by the way? Was it several people?
It was several individuals,
I don't know
of whom
the origin of that.
Rokitansky was one,
Okay.
the pathologist
Yes.
at Vienna.
Yes.
At any rate, I had internalized that dichotomy at that stage of the game and thought it better if I could find a portion of the extrapyramidal structures located in the basal ganglia in contrast to structures in the cortex and cortical projections.
Was there any experimental evidence to suggest that paresis or paralysis would not result by making a lesion affecting the basal ganglia, or specifically the globus pallidus?
No, but I simply thought I might be able to perform the operation with producing less disability than I had witnessed in the cases in which the neocortex was attacked.
So adjacent to the internal capsule. That's a
I
pretty
knew
small target.
I thought I could safely operate on the caudate nucleus and or the pallidofugal fibers in the ansula lenticularis without at all damaging the anterior limb of the internal capsule. Because the anterior limb did not carry, as far as we knew, any so-called pyramidal projections. What it did carry was the frontocorticopontine tract, for which nobody knew the function, except that it made a connection with cerebella destined nuclei. It was a pretty shaky sort of a hypothesis, but it seemed to me I couldn't do much worse than was being done at the neocortical level.
Yes.
And so I entertained the idea and spoke to Dr. Browder about doing a basal ganglia approach. And he said, well, you know that Walter Dandy down at Johns Hopkins has said this is a noli me tangere. Don't touch me.
Yes. He had placed the seat of consciousness, so-called seat,
That
sort
was
of like
right.
the car for the soul, except in a different area.
That is right.
I think by occluding the carotid arteries and then the
That is
vertebral
right.
on one side,
Yes.
and then finally the patient developed or went into coma, never regained consciousness, and he concluded that it was the blood supply to that particular area.
Yes.
The
When in point of fact, what it was that he had allowed his patients to get hypotension at such a low level that the whole brain suffered. That was demonstrated by Dr. Poppin.
Yes.
Well, okay. Dr. Browder reminded me then that Walter Dandy warned neurosurgeons not to operate in the anterior striatum on either side, because he said that if you operate on either or both sides, you'll have a permanent and irreversible coma. So neurosurgeons internalized this, and Dr. Browder was one. There happened then an accident at the Floyd Bennett airfield in which a student at Columbia University, a young woman of about 18, walked in front of an airplane while her propeller was still spinning. And the accident wiped away the frontal lobes on both sides, but when she was brought into the emergency room at Kings County Hospital and I was called to see her, I could look right down into her wound, and she was talking as rationally as I presume you and I are right now. And I could plainly see the anterior striatum had been sliced on both sides, and everything carried away from it.
She had no motor deficit?
She had no motor deficit at the time. She was the daughter of a professor at Columbia University, and her father arranged for her to be transferred from Kings County Hospital. But she was with us in the emergency room for a few hours before that transfer was accomplished, and I summoned Dr. Browder to the emergency room, and he agreed that the patient was not unconscious and that both her anterior striata had been badly destroyed. he was then convinced that that an operation on the anterior striatum could be done safely. And so we simply waited until a young mulatto female, age 26, turned up for treatment of left hemi-Parkinsonism. And I explained to her that what I was doing would be strictly, she asked to have her left upper extremity amputated, because this had spoiled her whole life. The tremors had made her lose her job as a domestic. Her husband deserted her. Her children were afraid of her nervousness. And her whole life had been badly disrupted. And when I explained to her the risks that we would be taking, and told her that the operation had to be done under local anesthesia so that I could be sure the tremors were still present at the time the critical move was made, she said, "I don't care what the risks are. Even if I die, I'd rather be dead than suffer what I'm going through." And so I presented her to Dr. Browder on the next rounds, and he agreed with me that she would be the ideal one to tackle, in part because she only had left hemi-Parkinsonian tremor and no rigidity, sine rigiditate, it's called in those days.
Mm-hmm.
So that was how the operation was mounted.
And you transverse, though, the caudate nucleus on the right side?
I went in transventricular, a transventricular approach. But I knew that in making a transventricular approach, I would have to go through the cortex of the premotor region.
Yes.
And that it could always be claimed that whatever result came of this might have been due to that and that alone. And so when, during my stimulation, electrical stimulation of the motor cortex in order to identify it and its demarcations from the premotor, area 6, in the course of that, I produced a convulsion, which lasted for 2-3 minutes, in which he was unconscious.
From area 6?
From area 6.
Mm-hmm. What type of seizure?
It was a generalized seizure of very much the grand mal type.
Was this
now, this was not within my view, but was reported to me by the anesthetist,
yes,
who was under the drapes with the patient.
Was the operation being performed under local anesthesia?
Operation was performed under local anesthesia for the very reason that we had to have the tremor observable. I could go under the drapes with the anesthetist, but most of the time, because during the operation I had to be at the head.
Did that not disconcert the anesthesiologist a bit to have a grand mal seizure to occur?
No, because he'd seen that happen many times when I was doing operations for focal epilepsy.
Oh, I see. Mm-hmm.
The kind of work that Otford Förster had introduced in Breslau.
Yes.
No, he was not disturbed by that, and he was a very good observer.
Mm-hmm.
So we had to wait 20 minutes before, the seizure was over in 3 minutes, but we had to wait 20 minutes before the tremors returned, and the patient was able to communicate with me. Then, having gone through the cortex and into the ventricle, the caudate nucleus was easily observable, and it was no difficulty whatever to lift that out first with a small scoop, and then with a suction apparatus up to the edge of to the face of the anterior limb of the internal capsule. And when the caudate nucleus, the anterior 2/3 of the caudate nucleus was removed, the patient was free of tremor. And she was able to open and close her hand and squeeze the dynamometer as she had done during the pre-operative workup. And she remained without the tremor from that time on. And the moving picture, which I gave you this morning, is of that first case done.
But the surgery was limited to the head of the caudate nucleus, essentially.
Yes.
Was the relief sustained in her?
Not completely.
Mm-hmm.
And that made me know that that operation was not going to be enough. I knew I had taken only 2/3 of the head of the caudate nucleus out. And I knew in doing that, I was very close to the ans lenticularis, which was a much narrower channel through which these caudate nucleus and globus pallidus fibers were passing on their way to Forel's fields.
Yes.
And that it might be better for me to make a simpler operation by going to the lateral side of the foramen of Monroe and simply cutting the ans lenticularis.
When was the first time you did that?
And that was done within the next year.
But that presentation of the results of the first operation in 1939, did any critics or anyone making comments about the possibility of this having been secondary rather to Area 6?
No, but what
Area 6?
the greatest outcry against it was that this girl was simply a hysteric individual.
But there were motion pictures, I assume, showing a
Yes, but they thought she was simply
hard to mimic.
Autosuggestion on what she had been through in the operation. They thought autosuggestion was sufficient to account for her getting rid of her tremor, and they felt that this was typical of hysterical types of neurological manifestations.
All right. So about a year later, then, you directed your attention specifically to the ans lenticularis?
Yes.
And the medial part of the globus pallidus included or not?
No, not at that time. But that was done in 2 separate operations.
I see.
One on one side and then 3 months later on the other side.
So the second patient then had bilateral disease.
He had bilateral section.
With rigidity?
He had rigidity as well as tremors
How
and
old
akinesia.
Was
he was a
roughly?
Man about 40.
So not much different in age from the younger woman.
No, she was 26 when she was
Right.
operated on. Not greatly, no.
But
he was a very satisfactory case, although he was not completely free of rigidity, and his akinesia was completely unaffected, which made us sure that the mechanisms mediating tremor, rigidity, and akinesia are different in the brain. The paradigms must be different, otherwise these selective discriminations could not have emerged.
In the patients with post-encephalitic Parkinsonism, and I assume that both these first patients were examples of that.
Yes.
Did you find that there was an appreciable number who suffered from dementia as well? Or because in today's literature and clinical experiences, we don't see patients where it's thought that they suffer from post-encephalitic Parkinson's disease, but a rather high percentage of dementia is seen, perhaps 30% or so.
Yeah.
Is this a separate disease or different disease process that we're seeing today, leaving aside the drug-induced examples?
Yeah. I presume so. I presume it must be. For most of the Parkinsonian patients, by long odds, are those who are suffering from vascular ischemic changes. They can be manifest in not only in the parts of the basal ganglia I was dealing with, but they could affect any part of the cortex, neocortex and archicortex, the limbic system. They could affect the substantia nigra, the nucleus rubera, the reticular formation, and so on and so forth.
Did you ever feel that the presumed cause of the Parkinson's disease affected the results of surgery? In other words, post-encephalitic patients were likely to do better with tremor and rigidity than patients from other possible causes?
No. We had one case that resulted from a carbon monoxide poisoning. But most of them were the so-called arteriosclerotic variety and blamed on ischemia. But you see, we didn't have enough post-encephalitic cases to make a statistically significant series by which they could be distinguished from.
Infrequent then.
Yeah.
Yes.
And no, that. So I never came to such an impression.
Did you have anatomical confirmation of the sites of lesions in the early years of your not exactly prior to the stereotactic techniques being re-employed?
We had autopsies. We had permission for autopsies and did autopsies on only 5 of those early, I'd say pre-World War II series. It was difficult to persuade families once the patient had died to get permission for autopsy. We would have liked to autopsy every one of them.
Sure.
In the whole series. And that was all, we spoke of that always in informed preoperative information given to patients and families, that we wished that if and when this individual died, even if it was only 20 years later or 30 years later, that autopsy would be permitted.
Yes. I had forgotten to ask earlier about your early interest in surgery for epilepsy, and I wonder if you might tell us how you first became interested in this area of research and treatment.
Yeah, I could synopsize that very briefly by saying the chief motivation for my getting interested in that kind of surgery, which had been done by Ottfried Förster of Breslau, Germany, and other people long before I was a student. But a general practitioner in Providence who knew I had won a prize in the neurological course there made me a present of an old-fashioned tree find that had been in his family from the Civil War days. And I used that tree find to open the head of the dog and expose the cortex. And because I wanted to be able to map the motor cortex of the dog, I used a faradic current to stimulate the cortex, and in so doing produced an epileptic convulsion.
Was it a focal or generalized?
It was a generalized convulsion. And there is where I got the main motivation when I had the chance to begin to do the kinds of work that Dr. Förster and his American counterpart, Dr. Wilder Penfield, had been doing for some years.
Yes.
I wanted to go to study with Dr. Förster and got a Rockefeller Fellowship. But due to the fact that Förster was married to a Jewess in Germany at that time, he was being harassed and became sick and unable to continue his practice, and the Rockefeller people told me, "You'd better go somewhere else."
What happened to his wife, do you know?
I do not know the follow-up on that.
And I was mentioning earlier that Professor Spielmeyer in Munich in neuropathology was married to a Jew, and the Nazis made him distribute anti-Semitic literature on the street corners in Munich, and he got pneumonia and died. But his widow was able to get a visa to go to England, and the daughter was taken in by, helped into the country by Dr. Zimmerman in New York, Harry Zimmerman.
Yes, Harry Zimmerman,
and,
pathologist.
Yes, and she is still practicing psychiatry. The daughter is to this day.
Well, I did not know that.
Yes.
I'm so interested to hear it.
So it must have been about 1938 or so that those laws went into effect, or habit patterns anyway.
That's right. This was a very critical period. The war was officially started on September 1st, 1939, when Hitler invaded.
Somewhat unofficially started, but started.
Yeah, he just walked across the border, and the war was on.
Yeah.
The Poles charged his panzer tanks with horses.
Yes.
Cavalry charged them with swords in their hands, attacking these.
But nobody declared war until September the 3rd, I think.
Yes, that's
Yes.
right. England decided to.
Right.
France decided to come in with the Poles,
Yes.
and England followed.
Yes.
Oh.
But Professor Förster's work had stimulated your interest to apply this earlier interest of yours to humans.
Yes.
At Kings County, you had said, and you had operated then from what years approximately for epilepsy?
Well, let's say beginning in 1937, when I got back to Kings County Hospital from Boston, until World War II, until I was called to service in 1942, in October 1942, and I suppose I did 150
Really?
operations during that time for epilepsy.
Were they primarily over the sensory motor cortex?
Many of them were, but I would say most of them were not. They were
Really?
either premotor or prefrontal, as they called it in those days, prefrontal cortex, and some of them were back in areas 5 and 7 in the parietal cortex. Now, they were not limited in any sense to close to the motor strip.
This is probably a naive question on my part, an uninformed question, but I've been curious over the years as to why there seems to be a different seizure threshold in various parts of the brain.
Yeah.
Why do you think this is, or is it known why? And I don't know it.
I don't. You're right about that observation, but I couldn't give you an answer to
Well,
it.
I'm glad to hear that in a way.
No.
I was hoping we might get an answer.
There are wide variations.
Yes.
The motor cortex will respond to weak stimuli that would not evoke any movements, focal or generalized, when applied elsewhere.
Like
and
the
that was the
prefrontal
main means of identifying the motor strip as opposed to the premotor and prefrontal.
And it helps to account for the formerly long delays sometimes in making a diagnosis of prefrontal tumors.
Yes.
Because of their subtlety and the early occurrence of seizures over the sensory motor cortex. It's curious.
That phenomenon was complicated when Hans Berger discovered, or he didn't discover, but he convincingly produced brain waves that could be obtained from the skull. Then the focus of epileptic attacks was considered to be an epileptogenic focus, as then called, by the spike, the appearance of spikes.
He had some difficulty in convincing people that what he was recording really was from the brain.
Yes, at first they thought it was simply circulation in the blood vessels of the scalp.
The great support he got eventually from later Lord Adrian, but
that's right, in Britain, physiologist.
Acceptance, I think, of his ideas.
That's absolutely correct, Dr. Selby. Now, as my experience grew, once these spikes were available, as my experience grew, in the first place, a spike was not constant in one site, at one site. What Dr. Knott, our electroencephalographer, and I called a will of the wisp.
Yes.
It would skip around, and we finally wrote 4 or 5 papers which abolished the idea that you could rely upon the spike as an indicator of an epileptogenic focus.
Well, when you would finish extirpating an area that seemed to be the primary site, quite often it seemed like that the spikes responsible for the seizure were coming from the edge. And would you continue to resect the cortex way beyond the area that initially it appeared to be?
No. If we found what we thought was a spike, which we defined by the production of a convulsion of the type the individual clinically manifested, if we discovered that and extirpated it, we would not do anything further.
Even though
than
you
that.
still could take recordings of spikes on the periphery from which of the lesion.
Yes, because you could get spikes almost any way you put
Right. So that was
so
not
we
a reliable
recommended
index.
abandoning that as a criterion for operation, and it did have a favorable effect on the neurosurgical community in their dampening down. A lot of people by that time were doing that Otford First type of procedure.
Did your surgery involve ever the left circumsylvian area and language as you were operating on patients for epilepsy?
We would explore there, but would never extirpate. Our excisions were never bigger than in area than a 10-cent piece, a dime.
Oh, really? I see.
If we found an area that seemed to be an epileptogenic focus, we would excise it and not try anything beyond that.
Did you not sometimes have fairly large scars, though, from trauma, perhaps?
Oh, yes.
Tears of the dura?
If there were adhesions of dura mater or the leptomeninges to the cortex, yes, we would have to, we felt we couldn't do well by the patient by not excising those lesions. And
I was just wondering
but
if,
we never work into the language area, Wernicke's area, for example,
yes,
and even
say,
take out a 10-cent, an area as big as a 10-cent piece.
But in the inferior frontal convolution, did you ever stimulate there on the left? In Broca's area?
In Broca, yes, we stimulated.
What results would you
We
get?
never had a patient do what Penfield and Bowlby later
That's what I'm asking,
described.
really.
We never had such an experience of having a vocalization, much less a verbalization, produced there. But then the failure to produce that was common even with Penfield.
Yes.
Most of his cases did not give him those results of either dreams
Yes.
or other sensory reports.
Did you ever come to conclude, like Pierre Marie, that Broca's area does not exist, at least as far as language function? Or do you feel, as today, that it is an elaboration of language, and important for more or less almost the final common pathway for the expression, verbalization?
That was my concept of it, as it was even for the so-called voluntary motor cortex.
Yes.
My concept was that, quotes, the will, close quotes, or the individual's, quotes, volition, was instigated and implemented from the motor cortex, area 4.
Yes.
My concept was that that was simply the mouth of a funnel. That the function, and this idea was one of Hewlings-Jackson's, not mine. He said to discover an area of the brain which, being damaged, results in a dysfunction is by no means equivalent to localizing the function.
Yes.
And that was an important
Yes.
metaphor which did not deeply impress most of my colleagues.
I think it's really coming now to, in the past, say, 15 years or so, as a blending of the old concept, early 19th century concept of no localization of function.
That
to
was
the
Fleuren's
late 19th
idea,
century,
yeah.
right, to the late 19th century of sharp localization.
Yeah.
And now it's a blending of areas with
Yes.
predominant localization, but not sharp localization.
Yes. I got suspicious that what you're talking about must be so, way back when I was Dr. Browder's resident, because you could look from one textbook to another and not find the circumscriptions matching one another.
Yes.
A teacher of neurology would make one drawing of Broca's area or Wernicke's area or the transcortical distribution in between them, and you couldn't superimpose that on any other author's
Yes.
diagrams. And I had no reason to believe these individuals were insincere or trying or being deceptive. I simply concluded that nobody knew
Yes.
from case to case precisely what the circumscriptions should be.
Yes. I had felt this sounds very presumptuous, and it really is, I suppose, that Pierre Marie may not have, it's hard to believe that this might be true, had not thoroughly read Dr. Broca's first two papers. Because Broca described the underlying pathology, though he didn't section the brains.
No.
But just because of the size of the infarct and the damage, he could see that the lesion was much more extensive than just the area ascribed to him
Yeah.
later.
That is the trouble with all clinical research, Dr. Selby, as you know. We do not have the precision of, let's say if we attack some structure like the caudate nucleus, we do not have the precision of taking it and nothing else but it, which we can then readily check up at a postmortem microscopic examination. We don't have any such happy circumstances as that in clinical research.
But they found Tom's brain a few years ago in Paris in a jar. Dr. Boca's first patient, remember?
Yes, yeah.
And
1960.
right, they did a CT scan, a CAT scan of it, and the results were displayed at a centenary honoring Dr. Boca in Paris. Very interesting pictures showing the extent of the infarction of the left hemisphere, and more or less coinciding with where Boca said it was. But in any case, getting back to epilepsy surgery then, did you learn anything more about the left temporal lobe that more or less complements or adds to Dr. Penfield's work in Montreal?
No.
About
No.
sound and memory and things of that like
No,
that?
sir, I was not making observations in that domain. I was stimulating there, but I was not setting myself to critical inquiry.
When when you entered the United States Army, Dr. Sperling was in charge of the neurosurgical services for the Army, wasn't he?
Yes, sir.
And there were very few neurosurgeons at the beginning of World War II, at least in
Only
the
80.
United States. 80.
80 had board certification.
Yes. And how many initially were there, 1941, 42, in the United States Army?
I would say, I couldn't give you the exact
No,
Surgeon General statistics. I would say 3/5 of them were in the Army.
But in active service?
In active service, yeah.
Three-fifths?
Not only the Army, but also the military forces,
Yes.
the Navy, and
Now, you were sent first to England?
no, we were sent first to Belfast,
I see.
North Ireland.
And that was an evacuation hospital?
No, that was a general hospital.
General.
Yeah, made up of mostly members of the staff of the Long Island College of Medicine.
I see. And who were your patients primarily at that time? Were these evacuees from North Africa, or?
We would get many people who had been injured in bombings. At that time, the British Isles,
Mainly civilian
including North Ireland,
casualties.
Belfast particularly,
Yes.
were being injured by the German B-1 and B-1 bombs.
But Ireland itself wasn't
And by the
bombed.
Luftwaffe.
Yeah.
Oh, excuse me.
Ireland itself was not bombed, except
No,
by
Ireland
accident,
proper
maybe.
was not. Just
Right.
just Ulster, those 6 counties
Right.
of Ireland.
And then at any time, were you in England before going to the continent?
Yes, they moved me to Oxford, to a general hospital there, run by the University of Iowa,
Oh, really?
and that's where a connection for a later commitment was
Yes.
made.
But was it-
Sperling sent me to that hospital in right outside of Oxford.
when was this now?
That would have been in 1944,
Just before the invasion? then?
shortly before the invasion.
And that was to serve as an evacuation hospital?
No, that was
for-
a general hospital.
I see.
Oh.
You were talking about your military assignment in Oxford, and that the unit there was one from the University of Iowa, primarily,
It was a general hospital.
as a general hospital. Similar to the organization system, I suppose, of World War I, where American units went abroad, identified with their originating hospitals,
Yes, sir.
like the Harvard unit,
Very
etc.
much, yes.
And you mentioned that Dr. Scarf was, at that time, on your arrival, chief of neurosurgery of the unit.
That is right.
And then he was repatriated home. for illness, and then you succeeded him as chief of neurosurgery at the hospital.
That is right. Oh.
And it was through that affiliation that you were invited to go to the University of Iowa.
That's
to
the
assume
sequence,
the chairmanship of neurosurgery there.
Yes, sir. So when I was released from the Army, on March 31st, 1946, I could move directly from the Mayo General Hospital, where I'd been working back here in the zone of interior, directly to Iowa City without any loss of time.
Mm-hmm. Now, when you commenced your work at the University of Iowa, you resumed your interest in that had been interrupted by the war in involuntary movements and the surgery for involuntary movements.
That is correct.
Encompassing Parkinson's disease and subsequently, at least, in print, hemibilismus. And did that include, by the way, dystonia musculorum deformans?
Yeah. And included athetoses and choreas.
Yes.
Yes.
Now, you had mentioned that you had worked with Fred Mettler, the neuroanatomist at Columbia University, prior to the war, in developing a stereotactic instrument or guide.
Yeah.
Was it more or less similar to the Horsley-Clark apparatus?
Yes, in all principles.
Mm-hmm.
What
but a bit simpler
prompted
and
me
lighter in weight?
Beg your pardon?
But a bit simpler and lighter in weight?
Yes.
Yes.
Theirs.
Yes.
Being simpler and lighter in weight. They worked on mammals, mm-hmm. and they had an atlas for cats and for Macacus rhesus monkeys.
I've never seen their atlases.
I saw it when I was in Britain.
Mm-hmm.
What prompted me to get into stereotaxy, because I'd known of the animal stereotactic apparatus of Clark and Horsley, was that I wanted to have I wanted to work out a less traumatizing operation to get into the basal ganglia. And it occurred to me that we might be able to do the operation stereotactically by simply putting a probe down where we wanted it and cooking the lesion.
You decided then to use electrical.
This was before World War.
Right, but to use electrical coagulation.
Yes.
Yes.
And so, which was equivalent to the Bellevue apparatus,
yes.
To put it in simple terms, the Bellevue apparatus of those days.
But this would be a bipolar construction.
Yes.
Mm-hmm.
Yeah.
Mm-hmm.
No, Fred Mettler and I did not work together. I saw that the greatest difficulty for the human apparatus was to get rid of these fixations through the external ear, which would have been painful to any patient under local anesthetic. And so I thought we would have to use we'd have to use points of fixation through the outer table of the skull, perhaps reaching into the diploe, but no further than that. And for this, I sought a couple of conferences with Fred Mettler, who was not only a colleague but a friend, personal friend. He was at the Columbia University, P&S at that time, for advice on this modification of the Horsley-Clark apparatus. We had 2 sessions, and he agreed that 4 points of fixation would be better than 3, which I had already concluded. And that was about the limit. But I made a few sketches with pencil and paper with Fred, and he modified them to fit crania of different sizes and shapes. Brachycephalic, mesocephalic, scaphocephalic, and so on. And that was the respect in which Fred and I collaborated in this. We didn't work together.
You were working with him mainly on the external fixation and
Yes.
the external landmarks.
We didn't really need to do anything in principle different than
Yes.
and I never thought that was any great contribution to simply take over what somebody else had already worked out and adapt it to the human. I never thought at the time that this would ever become a matter of dissension between other parties in the
Yes.
profession and myself.
Did you originate the idea of using the anterior commissure as a landmark?
No. No.
Who was that?
Oh, I forget. I wrote a paper on the variations of the anterior commissure and its relations, spatial relations to other structures that we were dealing with. But I myself didn't think of the anterior commissure as a...
It wasn't yet in use when you were... The anterior commissure was not yet in use as a landmark?
Not that I knew of. When Spiegel and Weiss's were at work in Philadelphia on a similar, very similar problem, but not for the types of operation I was doing on the basal ganglia, I had no notion they were working, and I presume with all faith that they had no notion I was working on that same problem. We were working independently we know, for at least 2 years without knowing about it.
Well, they were doing what would today be called functional neurosurgery, but you were too, of course.
Yes.
But it was more what used to be called psychosurgery.
Yes, sir. That's right.
And so their targets and interests were different than
Sure.
yours.
Yeah,
Did they use initially a modified Horsley-Clark design too for their stereotactic?
Not initially, no. But they came around to realizing that they could do the operation, they could perhaps do the operation more safely and comfortably for the patient by using a stereotactic instrument.
But they were trying to simplify the target and size of lesion to replace possibly frontal lobotomy.
That was what initiated the work. There were many modifications of frontal lobotomies, both in the cortex and in the limbic area.
Yes.
And they were, that was what engaged their interest.
Yes.
How they could best do this and where.
Did you ever become involved in psychosurgery?
Yes.
In those years?
I did at least 200
an open
prefrontal lobotomies.
A basal medial approach?
Yes. I did maybe 10 or 15 of them. And then Walter Freeman and James Watt came along with their transorbital approach, and I did the rest of that 200 cases that way.
Would Dr. Watts feel that he had been a participant in the transorbital approach? I thought that was one of the contentions that he and Dr. Freeman had.
It was.
Dr. Watts preferred more selective.
He preferred the conventional approaches that a neurosurgeon and myself did, because we always felt bleeding could get underway, and we would never know it until the patient was back in his ward, and that we would not be accessible, because we would be operating in some mental hospital far away from our headquarters, where we had the facilities for quickly opening a patient and dealing with a hemorrhage.
Did you choose eventually to use a more selective frontal leucotomy, say, rather than the more radical prefrontal?
I never did get into that. I was more and more focusing on my own work with the abnormal movement disorders.
Because I was trying to bring this back to Fred Mettler again.
Yeah.
And the Greystone report he completed.
I didn't see Fred after World War II at all.
I see.
I saw his wife Cecilia, but I never saw Fred himself.
She wrote a very fine history of medicine.
An excellent, superb history of medicine. Yeah.
Was she an MD, by the way?
Yes. Yeah.
But her specialty was medical history, or
medical history.
She'd concentrated that all the time.
We have.
Okay. I wanted to go on then with the involuntary movements. What was more or less the next major step that you took? The application in the stereotactic tactic techniques with electrocoagulation of the ancilla lenticularis primarily or entirely?
That was the main approach, except for hemibilismus, which went back to the operation that Clemmy did for Parkinsonism, which I applied as a first try in a case of hemibilismus and found that it abolished the abnormal movements.
You had recommended in one paper that surgery be done fairly quickly in hemibilismus.
Yes.
Why? Because of the disturbing and associated depression often accompanying hemibilismus?
Not so much that, but because these violent movements affecting one or both limbs on one side of the body, and some cases were bibilismic, of course, they were harassing the patient in all his wakeful states, and a tremendous amount of energy was spent in executing these movements. Over time, the patients became exhausted, and that was the cause of the deaths that had been recorded.
And some committed suicide.
And some,
Yes.
I felt that as there was no prospect by the use of medicine or psychiatric devices or anything of the sort available to the hemibilismic patient, we had better get at him before he got to the stage of exhaustion, and therefore recommended that the operation be done as soon as the diagnosis was made and the patient was prepared.
What was your final target for lesion making in hemibilismus? Where eventually did you evolve?
The final target was the ansel lenticularis.
Yes.
There, the
converging
the delivering
pathways.
portion of the funnel of all these impulses from the basal ganglia and cortex seemed to come together in a conveniently
And that
closely
was
placed,
that
but
true for
it meant
dystonia?
going through a part of the hypothalamus, namely the
Yes.
dorsomedial nucleus.
Right. Did that affect the appetite, by the way?
We never had a case
weight
that
gain
showed
or
either
anything like that?
augmentation or abolishment
It's
of
interesting. In recent
appetite.
research, that's borne out
It's
as well.
right in that region, yes.
No, I mean, it was once thought it was very sharply circumscribed, but in recent research, they found that it doesn't seem to hold true
Well, that is true,
in humans.
Dr. Selby, as far as I can tell, about every vegetative function. There are many areas
Yes.
from which those functions can be modified, either augmented or diminished or abolished in different parts of the limbic and basal ganglion system.
Did you find the ansel lenticularis to be the best target also for dystonia musculorum deformans?
Yes.
And
Yes.
in fact, all involuntary movements?
I didn't ever try it for hemibilismus because the undercutting operation worked.
Of area 4.
And I really only had four cases,
Yes.
four cases, I
Yes.
think, of hemibilismus.
But the other involuntary movements all best responded to lesions of the ansel lenticularis.
Yeah, and that included the operations on the crura of the midbrain that
Yes.
other people
And
had
Dr.
done, and
Busey,
which
for
I did
example.
some for cerebral palsied chorioathetotic sufferers.
Yes.
Yes.
And Dr. Busey with the pedunculotomy, so-called, finding no motor deficit in a number
Cutting
of
the
instances
pyramidal
anyway.
tract in the
Yes.
crura, yes.
Nevertheless, relieving Parkinson's disease.
Yeah.
And casting doubt upon the concept of the extrapyramidal pyramidal systems as being distinct.
Yes.
But I wanted to ask as well about the controversy with the targets in the Globus Pallidus, because Dr. Cooper had emphasized the importance, I remember in the late 50s, of the Globus Pallidus being the critical area to be affected by a lesion, and not so much the ansel lenticularis. In the debates that I recall, one must produce some weakness in order to get a very good result from Parkinson's surgery. And that there must be some encroachment upon the internal capsule accidentally to account for the excellent results in the early years. But you were deliberately, from the beginning, making your lesions in the ansel lenticularis after the first few.
Yeah.
So how did you just sit back and watch this debate that was continuing?
No, I
for
didn't sit
years?
back. I was present at pretty near all the major
But how
national
could
meetings,
you keep
and
out of those exciting
I
phrases?
didn't keep out of them. you look at the transactions of the American Neurological Association for those years, and I was putting my mouth into, I was discussing them whether they asked me to discuss them formally or not.
Well, lay people think political debates are ferocious, but sometimes medical and scientific debates are worse. And
well, I predicted when Cooper first presented his case, which occurred when he was proceeding to do a crural section, like Paul Busey and others had done, and accidentally broke the anterior chorioid artery and quit right then and there. And the next day, his patient was free of tremor. And I maintained that this could not be relied upon. He proceeded then for the next few cases to cut the anterior chorioid artery as his main endeavor. And I said, because I knew the variations of the circulation of the base of the brain, I knew that there was a tremendous variation in what the anterior choroidal artery would irrigate in the depths of the brain, and made the prediction that this operation would never hold up, and said so. And when Cooper presented it right there at the meeting, I wasn't at all on uncertain ground on that. And of course, he had to quit that operation because it didn't work in so many cases. That's when he started to tackle the further extension of the ansula lenticularis over a much wider area into the base, into the nuclei of the thalamus itself.
Yes.
Now, the ansula lenticularis had to go over the zona incerta, inferiorly of the zona incerta, while the fibers coming from the nucleus ruber into the thalamus came over H1, which was superior to the zona incerta. He, in effect, put his cold probe into that more widening out of the ansula lenticularis, and that's where what successes he began to report rotated upon.
Well, did you find in your patients that you had to, after a few months or a couple of years, repeat the operation because of recurrence of symptoms?
No, if the symptoms recurred, we did not. I never did a pallidotomy. I would not.
But that was a common problem with pallidotomy.
Yeah, it was a common problem. That gets you into a depth of the brain which, if you start a hemorrhage up incidental to your surgery, you'd never be able to reach without killing the patient, I'm sure. So I never did a pallidotomy or a pallidectomy.
But the results often required, if they were beneficial, a repeat operation, usually making the lesion more posterior until the thalamus eventually was selected as the best target.
Well, that was not my preference, but Cooper's preference.
Yes.
To deal with with that component of the ansula lenticularis, which went into the ventral medial nucleus of the thalamus. Now it spreads out and goes to many other places downstream, as you know, the substantia nigra, the substantia nigra and the red nucleus, and all of the tegmentum of the midbrain below that in the peduncle.
It's part of the feedback loop.
Yeah, it's a part of a complex feedback loop. And apparently that loop had to be intact if you were to get these abnormal movements.
Yes.
And if you interrupted it anywhere, most conveniently, you had a chance to get a favorable result.
Approximately how many patients with involuntary movements did you operate upon now before we get into ultrasound?
I would say, I'd have to look it up for sure now, but I've recently been through it, roughly 105 and altogether. And I never recommended this as an operation. I said, we are doing an experimentation here, and I still think I consider we are still in it. I repeated that over and over again at meetings and in my writings. Cooper was already advocating it as a standard operation and collecting fees for it. I never collected any fees for my patients at all because I felt they were a part of an experiment, as I was.
I'm not sure it was the first application of ultrasound in medicine, but a very early application at least, was that applied to the treatment of Parkinson's disease by you at the University of Iowa. with the physicists from the University of Illinois in Urbana.
That's right.
Could you tell us something about that? I understand a bit how it came to be at the University of Iowa, but what did it consist of, really?
I was continuing to look for a simpler way of doing a precarious operation, or an operation that many of my fellow neurosurgeons preferred to steer away from. Bill Fry, Professor Bill Fry, a biophysicist from the University of Illinois at Champaign, published a paper on the use of a stereotactic instrument in monkeys for making lesions by means of focused ultrasound. That is, bringing particularly 4 separate inputs of ultrasonic energy from transducers, which energies were not sufficient to damage the transgressed brain, but which, when converging, were such as to produce a tiny lesion of about 1 millimeter volume, which lesion could be increased to any size or shape by simply shifting the apparatus along the 3 axes of space. That paper was published in 1954. It appeared in the American Journal of Neurology, Psychiatry and Neurology. I read it and saw at once that there was a possibility that the answer lenticularis could be the focus. So I made an appointment and went over to see Bill Fry and his brother, an electrical engineer in the same department at the University of Illinois, and told him what I had in mind. He got enthusiastic over carrying this experiment into the human realm, and the result was that we agreed to do the technical work that they had started on animals, and to do the human cases in Iowa City. And so we got permission from the dean and a grant to use 2 rooms, one about the size of this room for the operating room and the apparatus, and the other in the room above us for the operation of precise operation of the stereotactic instrument.
How reliable or predictable were the lesions on the ants and lenticularis in the animals you studied?
Where were they?
No, how reliable was this technique in producing the lesions of the ants and lenticularis?
How precise?
Yes.
Yes. It was not highly reliable when we started. And we would have to search around, move the stereotactic, hold the stereotactic instrument from above, move it around to where we thought we had erred. And we kept a record of every shot we made on a computer. That computer was the iliac computer at the University of Illinois, which is the second big computer,
which probably
ENIAC being the first one, which was on Long Island.
And probably took up another big room. Yeah.
It took up the part of the room up above us, and but we got better and better at it. While we didn't have, not many patients died. Maybe out of the whole series, we lost 8 or 9 of them. We had the chance to check these by autopsy in only 3. One of which we aimed at, not at the ansa lenticularis itself, but at the at Farrell's fields H1 and H2, and we hit it clean, perfectly. You can see the lesion in the white matter above and below the nucleus of the zona incerta.
Subsequently, you used this also for functional hypophysectomy or ablation of the pituitary.
Of the pituitary. That was a much cruder
right.
type of operation. But it used the same apparatus. that was a concept of my colleague in the general surgery department, Bob Hickey.
Yes.
And Hickey headed that project.
Yes.
But I simply turned the bone flap in those cases.
See. But was it effective in totally destroying the pars distalis?
Yes, those we could get autopsies on, showed that it was destroyed, but our reservation was that since the sella turcica, which is made of bone, was so proximate, we couldn't be sure how much of the destruction was achieved by the ultrasound alone, and how much was due to bound back of heat from the bone of the sella, of the basket of the sella turcica.
Yes. I wanted to ask, in sort of summing up about the evolution of your thought, or perhaps some conclusions that you may have reached about the way that it's best perhaps to think of the motor system. And one thing I've often wondered about is why certain types of involuntary movements occur in association with certain types of pathology or lesions or locations of lesions, and others with other locations. And I've never really come to any conclusion about that. I can't explain it.
Well, neither can I at all. I can say, though, and resort back to what I said 10 or 15 minutes ago, that any of these neural functions we talk about have multifocal areas whence they can be modified for good or ill.
Yes.
That includes Parkinsonian tremor, for example. And Spiegel used to insist that the only pathology of Parkinsonism was the substantia nigra.
That's post-encephalitic, perhaps.
Well, not necessarily limited to that. He didn't limit it to that, but he insisted that that was the one, that was the sine qua non of the production of tremors. I insisted that there were many such areas, and that the substantia nigra was one and only one of them.
The most obvious one, perhaps.
Yeah. Now, as the years went along, it turned out, as a result of the experiments on levodopa, that the substantia nigra was the critical structure mediating the precursors of dopamine.
Well, though our textbooks still quite often divide the motor system, especially pathology, in the extrapyramidal and pyramidal, or diseases of each, is it not a bit late to sort of try to unify our concept of the motor system? Though that's even a bit arbitrary, trying to separate it out from everything else.
I don't think it's ever too late, Dr. Selby. I think it is urgent that we must revise our man-made categorizations, which I impute to man and not to the objects presumably of interest by most of my colleagues. This dichotomy between an extrapyramidal and pyramidal system is ridiculous. For one reason, we don't know what the pyramidal system is. You only know about 3% of it coming from Bet cells.
Yes.
And there are many other fibers running in the pyramidal system. So we have to say we don't know what the pyramidal system is right today. If we don't know what that is, how the heck do we know what the extrapyramidal system is, which is vastly more complicated?
Yes.
And for us to go along and framing our research and our endeavors at the operating table or anywhere else in terms of a dichotomy which is strictly a man-made fiction is to defeat yourself over and over again by iatrogenic methods.
Yes.
And that is my
in a way, this
conviction.
goes back to an old term, the integrative action of the nervous system.
Yes, of course it does. And what I had to say applies to dozens of dichotomies, of which the dichotomy of pyramidal and extrapyramidal is one well fixed. Even though I protested in print about it, that hasn't modified my fellow men at all.
Yes.
The concept of the dichotomy between organic and functional diseases is a second one.
Yes, it's becoming impossible to use the two terms because, especially in mental illness, we're so often talking about biochemical alterations underlying it, and the term functional no longer means anything.
It does not.
But
And as long as you
organic.
use that as your
Yes.
your vademecum,
Yes.
you're in trouble. It's going to cripple your research
Yes.
because you're using the wrong terms.
Yes. Over the years, you've written occasionally about medical education and concerns about medical education, and probably in part related to your own experiences as a student. Towards the end of this interview, I was wondering if you could maybe make some observations and comments about undergraduate and postgraduate medical education.
Yeah. Well, the principles that I that I've advocated at the levels of medical education also apply to education from kindergarten on. They are that our whole culture, what we call Western culture, and that includes Western medicine, of course, and Western neurology, is prefaced on the Aristotelian concept and his logic. His logic is basically an either-or logic. It is like the logic of a computer. It says yes or no, in or out, up, down, dit, dar, and so on. That Aristotelian logic is built upon his three laws of thought. The law of identity, the law of non-contradiction, and the law of the excluded middle. All his logic is either-orish, and most of my present people in Western culture, without ever knowing there was such a person as Aristotle, right up to the people that sit in the Supreme Court today on the question of abortion or no abortion, are suffering from the exercise of Aristotelian logic.
What steps do you think might be taken in medical education, especially relevant to neurosurgery, to try to escape from this?
The first
long
step is to
tradition?
recognize what I've just said. They are living in terms of
That's the
formulations that were satisfactory 2,000 and more years ago. Aristotle died in 322 BC.
So, as so often happens in neurosurgery, we're left with questions rather than answers.
Yeah,
in
but
this
we don't
interview.
realize the question. We don't realize their questions. We take them to be facts, which I think should be put in quotation marks.
Yes. Yes.
And that is another of the points I emphasize in my papers on education.
Yes. Well, I want
That we'll have to shift from an either-orish to a continuum concept between blacks, grays, and whites.
Yes.
This is really the essence of all that I've had to say, no matter what the special focus of my papers on education might
I
be.
wish we could go on for another hour or so, but I want to thank you very much, Dr. Meyers, for
been my
giving
pleasure.
this interview.
It's been my
Thank
pleasure,
you very
Dr.
much.
Selby, and thank you for being so patient.
Oh, yeah, I've enjoyed it very much.
Thank you.